Is YAG-PA indicated in all cases of primary angle closure suspects?
Good morning, ladies and gentlemen. At the outset, I would thank Dr. Girja and KSOS for this opportunity. Our previous speakers have spoken about angle closure glaucoma, its classification and imaging. The question I would like to address is YAG-PA indicated in all cases of primary angle closure suspect? The mechanism of angle closure, as you know, YAG-PA really only helps in the case of pupil block or relative pupil block, where you have an iris Bombay-like appearance. But there can be other mechanisms like plateau iris configuration, lens-induced or lens factors, and ciliary block and posterior pushing mechanisms. So really, YAG-PA does not help in these. It's mainly in the case of pupillary block. So the question I'm trying to address here, this is what is usually recommended. The indications for YAG-PA in primary angle closure suspect are: one, if there's a history of primary angle closure in the other eye, or if it's a one-eyed patient. A relative patient requiring frequent dilatation. As you know, Kerala is now the diabetic capital of India. So many of our patients are diabetic and they need once yearly at least dilated fundus examination. People unable to come for regular follow-up. Now, as you know, with the changing demographics of Kerala, all of our youngsters are moving away to UK and Canada and US. And so our elderly patients very often go to visit them for extended periods of time, 6 months, a year, or maybe longer. And unfortunately, in places like UK and Canada, the healthcare, our access to healthcare is not great. And very many of them are not able to see a doctor or an ophthalmologist when they are there. And as you know, US also, it is completely controlled by insurance. So this is also something that we need to keep in mind. With increasing longevity, more of our patients are on medications, asthma, Parkinsonism, allergy. Unfortunately, a friend of mine, his mother, unfortunately developed bilateral angle closure due to treatment for acute asthma. So these are considerations that we need to keep in mind, and it's not just the eyes that we are looking at. We need to consider the patient as a whole. I had two patients once who had seen, and I thought occludable angle, and then when I gave them an appointment for YAG-PA, when they came, the angle had opened relatively, and then asking them, they were taking medication for allergy the first time when I was seeing them. So all these are things that you need to keep in mind. Symptoms suggestive of previous primary angle closure, definitely they are patients that you do not want to wait and sit on. Patients should understand the risk, and then with their consent we can do a YAG-PA. YAG-PA is not without its complications, which is why we always need to keep that in mind. So usual complications like bleeding, corneal pitting. Some complications are very disabling, like dysphotopsia. It's the patient who had a YAG-PA. Unfortunately, the PI is just exactly where the lid was cutting the limbus, and he had severe dysphotopsia symptoms. Another patient who had a YAG-PA done elsewhere came 17 days post YAG-PA with a complaint of floaters, and he had a retinal hole with an operculum exactly corresponding to the PI. So unfortunately, the YAG laser had gone through the iris and hit the retina. So this is always something that we need to keep in mind. So the reason for our rethink is these two big studies, the ZAP study from Guangzhou in China and the analyst study from Singapore. The ZAP study had a first results which came out in 2019 and then followed in 2021, and the analyst in 2022. And let's have a brief look at these. So the ZAP study, nearly 900 patients followed up for 6 years, all with PSCS. And what they looked at was the risk of primary angle closure. So there was a 50% reduction in risk of primary angle closure if they had a YAG-PA done. But the numbers needed to treat was 44. And there was a hazard ratio of 0.53. Now the follow-up, they did follow up these patients even further, and they came out with a 14-year result where the numbers needed to treat came down from 44 to 12.35. So in effect, you treat 12 patients to prevent angle closure in one patient. I think that is still justifiable. I feel even if you can prevent one angle closure, I think it is justified. The other big study was the analyst study. You can see here again nearly 500 patients followed up over 5 years, and again you can see there's a 50% reduction, 11 versus 21 in the treated and the untreated eyes, and the numbers needed to treat was 22. This is a patient I saw with acute angle closure, as you can see, it's really a real struggle to get them, treat them and get them to get the IOP under control. So, and also this article came out in IJO recently, February 2024. You can see the rough ratios of primary angle closure suspect, primary angle closure, and primary angle closure glaucoma, 10:2:1. So this is why people are rethinking whether we should go ahead and do a YAG PI. And also they say that once the patient has had an acute attack, even doing the YAG PI may not really solve all the problem, because many of them have got a iris atrophy, angle closure, which is also synechial closure, which does not really open up with the YAG PI. So what do I do? Of course, a good clinical examination, AC depth, iris configuration, gonioscopy. So make sure this is a patient with a relative pupillary block in whom you are actually justified in doing a YAG PI. With this clinical examination itself, you can differentiate those patients who actually have a relative pupillary block, the peripheral shallow AC with a convex iris. That's the primary angle closure that we need to address. But in the other cases, where the whole anterior chamber is shallow, most likely it is the lens factor that are operating, and also central and peripheral shallow AC, the forward movement of the lens. Irregular AC depth probably means an irises, lens subluxation, and other factors. So those are patients where YAG PI really is not going to help. And again, clinical examination, where you can image them and document them. And as I said, history of drug use, history of travel, all these need to be taken into consideration when you manage the patient, and discuss with the patients, and if suspicious, do a YAG PI. Thank you.
Thank you, sir, for that excellent